Thank you, Vikas, for doing all the jugglery for my presentation, and finally I landed on time. So what I'm going to do is to discuss the evidence-based recommendations and practices in neutropenia care and precautions. So Akhil has already spoken about febrile neutropenia, the most dreaded complication of the neutropenia. And as we all know that when we talk about neutropenia, our understanding is that the count should be less than 1,500. However, the worry comes in when we talk about the severe, the protracted and profound neutropenia, and that's where we worry about. One thought which needs to be kept in mind that it's not just the absolute count, it's the functional neutropenia which can also be there. So your counts can be normal or they can be low normal and the person can be having functional neutropenia. It can be in several situations, commonly what we see in acute leukemics. And what we worry in this situation is infections. Where do these infections come from? And that's what we need to prevent or take care of to avoid frequent episodes of infection, which can be potentially life-threatening in close to 10 to 15% of individuals, depending on what particular disease we are looking at and what particular situation we are in. So what measures can reduce the infection? As majority of these infections are endogenous from the patients itself, we need to look at and counsel patients regarding patient-related factors, do interventions which can reduce the risk of infection in this particular neutropenic patient. And then the second part of it is environmental. So amongst the patient-related measures, the common ones which we normally have been thinking or have been looking at or the evidence is being generated is towards the personal hygiene, low microbial diet or what we call as neutropenic diet. The common sense says that to avoid infection, you need to give prophylaxis. So is there a role for antibiotic prophylaxis and antifungal prophylaxis? Growth factors prophylaxis, and commonly these patients require vascular access devices to administer chemotherapy and supportive care. So many times the infection comes from these vascular access devices, poor handling of these devices in these patients. These several environmental measures have been in place because a lot of these patients who have protracted or profound neutropenia are ultimately hospitalized. Some of them are on outpatient basis. So several measures have been instituted to reduce the risk of febrile neutropenia in these neutropenic patients, like HEPA filter, isolation, protective clothing, face mask, and several visitor and social restrictions. So what I'm going to do in next few slides is to give evidence whether any of these measures which have been instituted over a period of time are just feeling-based or they are evidence-based. So that's what I'm going to do. Hand hygiene is indisputable form of preventing the infection from patient to patient, from healthcare to patient, and even otherwise from the environment. So both the patient as well as the caregivers and the healthcare professionals should be practicing the hand hygiene before and after the contact with the patient, as well as when the patient is going to the bathroom or before consuming food or before touching any surface, before and after touching any surface which can be potentially contaminated. So this is indisputable and I'm not going to talk much about it. There are several other measures because we all know that the infection is endogenous, so most of these bacteria either are present on the skin surface or they're present on the oral cavity or on the GI tract. And many times these individuals get colonized. Longer they stay in the hospital, the higher is the risk of colonization with several organisms, including the multi-drug resistance organism. In the ICU setting, there has been several studies which have looked at chlorhexidine gluconate bathing. And what's the evidence? Some studies were positive, others were negative. So obviously to solve this quandary, they did a systematic review and meta-analysis. And if you look at all these studies, in the ICU setting, this is not specifically in neutropenic patients, it has been shown that chlorhexidine bathing reduces the skin colonization, reduces the hospital-acquired bloodstream infection, reduces the catheter-related bloodstream infection. So it seems like this is an effective measure. However, we all know that bathing is something which is subjective. How well it is done, how frequently it is done is going to have a difference. So whether that can make a difference in neutropenic setting do we have a data? So again, small studies in neutropenic patients, both in pediatric as well as adult and in the transplant setting. And if you look at this particular study, If you look at the lower part, which is what is the group which received the chlorhexidine bathing, and in this group, especially in individuals who are, or the kids who were more than 12 years of old, the risk of febrile neutropenia was much lesser, infection rates were much lesser. So seems like a beneficial method to reduce the risk of infection. There are several small studies which have been done in other hem-onc patient and transplant setting, and if you look at it, most of them have supported the use of chlorhexidine bathing, provided we all know that the fidelity of the bathing is maintained. Next important site which can be the focus of infection or can be source of infection is oral cavity. Again, there were several studies, several measures how to best do the oral care, and based on this, the position paper was published from the MAS and the ISO, and in collaboration with the European Society for Blood and Marrow Transplantation. What they say is that you need to take care of the oral cavity, reduce the plaques, reduce the solid food left behind after eating with the rinses. As well as there is some data to support that chlorhexidine mouthwashes reduces the microbial flora. So what's the best way? If you have planned chemotherapy, you have everything set, look at the dentition, look at the oral hygiene, and correct it with the help of a good dentist who understands what you are going to do down the line. If you don't have that time, like in leukemic setting where the person is already neutropenic, is already thrombocytopenic, and you may not be able to do extractions and major procedures, at least maintain this dental hygiene with twice a day brushing, if possible, whether they can do flossing if possible, and use bland rinses after each meal, which can be just a saline or soda bicarb based mouthwashes, or if there is a possibility, then you should consider doing chlorhexidine mouthwashes at least twice a day. So again, there is no randomized controlled trial here to suggest that this helps, but this is a common sense, and that's why this practice has been going on. A concept which has been there since I was training, or now people don't practice it so often, is what we call as low microbial diet, or what we call as neutropenic diet. What it means is no fresh food, no vegetables, raw vegetables, no salad, no non-cooked food should be permitted, and if possible, do the sterilization of the food before the patient eats. So that's been the concept. Do we have an evidence for that? I think the evidence is there both in favor in small studies, but this is one of the large study which is conducted in acute myeloid leukemia patients, looking at cooked versus non-cooked food, and their endpoints were time to major infection as well as survival. And if you can clearly see here, there is no difference in terms of time to major infection or survival, whether they received cooked food or whether they received non-cooked food. In fact, the fever of unknown origin was much more common in subjects who received cooked food. Pneumonia was more common in this particular subset. So we don't have a clear evidence to say that neutropenic diet or low microbial diet really helps these patients. So where we are, this was a choosing wisely thing published, and the reason why we've been practicing low microbial diet or neutropenic diet, because the sense is that the food or the fresh food which is there, fruits, vegetables, on their surface you have Enterobacteriaceae, and they come and they colonize these patients, and there is bacterial translocation through the gut, and that results in sepsis. When they looked at the cultures obtained from the patient's blood and what is obtained from the food surface, they're not the same strain. So probably what we've been doing is one of the things which we do for no reason. And another important thing which comes in here, that when you do sterilization, when you cook everything possible on the earth, including the fruits, the palatability goes down. And as some person who does not have taste as well because of the chemotherapy, in food intake further drops down. And therefore, you make them more nutritionally compromised. And it's a common sense, once you have a nutritional compromise, you'll have low albumin, and you'll have more GI edema and more gut translocation of the bacteria. So probably it's counterproductive there. Another important thing is the dietary fiber, because there is low dietary fiber, both soluble and non-soluble, the minute you start cooking and heating up everything, and that also has adverse impact on the GI motility and thus the gut translocation. So these are all thoughts behind the low, what you call low microbial diet, but there is no clear evidence to say that there is low microbial diet which reduces the risk of infection. So what is relevant is one needs to have a safe food handling, as we do for any other person who is not neutropenic. So it has to be pasteurized milk, it has to be a fresh freshly cooked food or a fruit which has been cut recently, not kept for a long time, to avoid the fungus growing on it and all sorts of bacteria colonizing. And definitely not the sprouts, because that requires humidity and there is a risk of bacterial colonization there. So this is something what is recommended based on the available evidence. Coming on to the antibiotic prophylaxis, the common sense says you give prophylaxis, you will have lesser risk of infection if you have neutropenic setting. Close to 109 studies were analyzed in a meta-analysis. 2 trials out of those 109 were large, and they both recommended that if you use fluoroquinolone in patients who have profound and protracted neutropenia, there is decrease in the risk of febrile neutropenia as well as all-cause mortality. This is fluoroquinolone. Looks very good because it's reducing the mortality, but this is only in protracted, profound febrile neutropenia with hematological cancers or the transplant setting, not in the solid tumor setting. Other problem comes, more than 30% risk of quinolone resistance in the majority of the setting. So places like ours where there is high quinolone resistance, where there is high incidence of pulmonary tuberculosis or tuberculosis as such, whether you really want to give them quinolone, they may not be as efficacious because this kind of studies have not included the population which is like ours. So something to think about. Moving on to the role of antifungal prophylaxis. Profound protracted neutropenia, we all know, predisposes towards the risk of fungal infection. So if you look at, again, the data from the ASCO IDSA guideline, it says that you should use antifungal prophylaxis in patients who have AML, MDS, or undergoing transplant, and you expect them to be neutropenic for a long period of time. What agent you are going to use? You use a mold active agent because invasive aspergillosis is a common problem there. And majority of the data is available for the posaconazole, and that's what can be considered. Other options are echinocandins. Moving on to the role of growth factors. So we all know that any chemotherapy regimen which has more than 20% risk of febrile neutropenia, we should be considering giving them GCSF. Other than just this, we need to think of other factors, which are host factors and the disease factors. So somebody who's elderly, has open wounds, have poor nutritional status, has got cardiovascular disease, renal dysfunction, multiple other comorbidities, HIV, even if you have a chemotherapy regimen which otherwise has a lesser risk, you would consider giving them GCSF as prophylaxis to avoid febrile neutropenia. Is there a preference in terms of what kind of GCSF you should be using? There isn't data to support one over the other. It all depends on the cost, convenience, and the clinical situation which you are handling. Moving on from the personal to the environmental related measures. We've all been seeing patients should wear masks. The healthcare workers should be wearing the protective gowns and clothings, and there should be visitors restriction and isolation. What's the data for this? So if you look at this systematic review and meta-analysis, which evaluated the protective clothing, antibiotic prophylaxis, and the isolation, the only thing which worked there was antibiotic prophylaxis. Nothing else was really helpful. So that's something which is to look for. Having said that, if you have transplant recipients or if you have allogenic stem cell transplant recipients or leukemic patients, using HEPA filters with desired number of air exchanges really reduces the risk of fungal infections. So aspergillus is something which you reduce. So that's one setting where you should consider in terms of these changes in the environment. Whether mask helps or not, this was a study conducted to reduce the risk of aspergillosis, and there wasn't any difference in the terms of risk of aspergillosis by use of the well-fitting mask. In fact, there is a suggestion that the patient might colonize the mask with their own bacteria and they would be inhaling it back, so we really don't know whether mask really helps or not. There have to be some visitors restriction to avoid if they have open infections. Flowers, because they contain soil, and soil has all these spores, and therefore they shouldn't be bringing flowers to you. And if somebody has received immunization with live vaccine, they should be having no contact with the patients who have neutropenia. Having said all this, this was a study which was conducted in acute myeloid leukemia patients treated with BFM 2004 trial. And what they suggest that there is no definitive evidence to say that so much restrictions really help. In fact, what they do, they probably impair the quality of life in an individual who's already compromised because of the ongoing disease as well as therapy. So that was my last slide. If there are any questions, I'll be happy to take.